Its diameter is greater than 3 millimeter, but this diameter, when you are measuring, it should be in the upright position with a demonstrable reflex. So it's a medical condition where veins cannot pump enough deoxygenated blood back to the heart. Or in other words, we can say that there is impaired musculovenous pump. This varicose veins mainly occurs in the legs, can also occur at other places which are CNS and liver. So this varicose veins includes telangiectasia, reticular veins, and varicose veins. So now we will explain these one by one. First of all, you should know briefly about the venous anatomy. You all know, I know, but should be a rehearsal for that. So the venous system is comprised of deep veins, superficial veins, and the perforator veins. The superficial veins are great saphenous vein and the small saphenous vein. The great saphenous vein, it begins from the medial marginal vein on the dorsum of the foot. It ascends in front of the tibial malleolus, and then it goes up and the medial aspect of the leg, and then it goes behind the medial condyles of the tibia and femur, and then it goes on the anteromedial aspect of the thigh and terminates into the femoral vein at the fossa avalis, which is 2.5 centimeter below and lateral to the pubic tubercle. The short saphenous vein begins from the lateral marginal vein behind the lateral malleolus. It ascends on the lateral margin of the tendocalcaneus and then goes up on the posterior lateral aspect of the calf, perforates the deep fascia of the popliteal fossa and empties into the popliteal vein. There are deep veins which are located within the deep fascia, and the blood flow is greater in pressure and volume in these deep veins, and they account for 80 to 90% of the venous returns. Perforators, they are veins which connect the superficial with the deep venous system. They pass through the deep fascia and they are guarded by valves, and this valves, it prevents blood flow in one direction, that is, the blood will flow from superficial to the deep veins. Now there are different types of perforators. At the level of ankle, they are May or custard perforators. At lower leg perforators are called coquette perforators, which are 1, 2, and 3 according to the level. And the gastrocnemius perforators, of which are called Boyd, and the mid thigh perforators, they are called Dodd. And there is also Hunter's perforator in the thigh region. So what is the physiology of venous blood flow? Venous return from the leg is governed by arterial pressure, calf musculovenous pump, gravity, thoracic pump, and valves in the veins. So this musculovenous pump, they are located in the foot and calf muscles, and when they contract, they squeeze the blood out of deep veins. And there is one way valve. They only allow blood flow in one direction, that is upward and inward flow. During muscle relaxation, blood is drawn inward through the perforating veins. So now if we come to the pathophysiology of chronic venous insufficiency, so there is 3 mechanisms in its formation. One is the primary muscle pump failure, The second one is the venous obstruction, and the third one is venous valvular incompetency.
Primary muscle pumping liver venous
Now see at these two pictures. On the right side there is a healthy vein with its intact valve. It allows only blood flow in one direction. And in the other picture you see there is dilated veins, and the valves, they are aparted from each other, they are defective, so they will cause the blood flow to move in both direction, and this reverse flow will cause a elevation of the venous pressure. So there are, if there is any risk factors, it will lead to the increased venous pressure. This increased venous pressure will ultimately lead to the dilatation of vein walls. When there is dilatation of vein walls, there will be stretching of valves, valvular, and it will lead to valves valvular incompetence. So this valvular incompetency will lead to reversal of blood flow, and also when there is failure of muscles that is pumping the blood, it will further distend the veins, that will result in elongation, tortuosity, and there will be pouched out. These veins will be inelastic and friable. So there are some smaller varicose veins which are called telangiectasia. These are small. The diameter is usually from 0.5 to 1 millimeter, and these are intradermal varicosities, also called spider veins or venulectasias. They occur anywhere in the body, but particularly an important one for us for today lecture is legs. So they are mostly in the legs. They usually cause mild symptoms. The symptoms are not severe, so rarely need treatment, and they are rarely hemorrhagic. The other term is coronaphlebectasia. This coronaphlebectasia are blue spider veins on the medial aspect ankle below the malleolus. These are telangiectasia. So reticular veins, they are larger than the telangiectasia but smaller than the varicose veins. These are located in the subcutaneous tissues. They are dilated veins, and they enter the tributaries of main axial or trunk veins. Their diameter is more than the telangiectasia, which are range from 1 to 3 millimeter. They can cause some discomfort, and cosmetically it's undesirable. This is reticular veins. Another picture showing reticular veins. So if you can see, it's not cosmetically good and also causing some discomfort to the patient. So now come to the varicose veins. So these varicose veins are dilated, tortuous, and elongated veins with reversal of blood flow mainly due to valvular incompetence. This varicose veins only occurs in the humans because of the erect posture, and they have only legs to walk. The animals, they are having 4 legs and less effect of gravity. So in 4 legs animal, this is uncommon. This varicose veins can occur in the legs, can occur in the anal region, which are called hemorrhoids, can occur in the scrotum, leading to varicocele formation, and also there are esophageal varices. These are types of varicose veins. So now come to the risk factors of varicose veins. First of all, age. As the age increases, its risk of formation of varicose veins is increasing. In the gender, they are more common in the female because of pregnancies, and pressure on the pelvic veins, and ultimately leading to the pressure on the lower leg veins. So in females it's more common. Height, the tall people, they are more prone to varicose veins formation. Left side is usually more affected than the right one, and there are also some hereditary contribution to the varicose veins formation. Pregnancy, obesity, and overweight. These are also risk factors for the varicose veins formation. Postures. The men who are walking all the day are their job description is standing, like teachers, shopkeepers who are standing all the day, so they are more prone to the varicose veins formation. So in the lower limb, the main etiology is erect posture, and there is primary varicosities also, which are in which there are congenital incompetence or absence of the valves, weakness or wasting of the muscles, or stretching of the deep fascia, or inheritance with FOXC2 gene. And the other condition, Kleppel Trenone syndrome. And in these conditions, there is more chances of varicose veins formation. Secondary varicosities. Secondary varicosities are those cases who are having varicose veins due to some etiologies like recurrent thrombophlebitis, some occupation, obstruction to the venous return, for example, in case of abdominal malignancy, pregnancy, iatrogenic and AV fistula, and deep venous thrombosis. These are factors leading to the varicose veins formation. So this is a brief view showing the primary, secondary, and congenital varicose veins. But in all these, the pathology will be the same. There will be dilated veins and there will be venous valve incompetency. So ultimately, it will lead to chronic venous insufficiency. So when there is varicose veins or chronic venous insufficiency, you will have three types of features. One is the symptoms of these venous chronic venous insufficiency, and which are the pain and tiredness at the end of the day. And the second feature will be dilated veins. In terms of varicose veins, reticular veins, or telangiectasia. And the third type of features occurring in chronic venous insufficiency will be the post-thrombotic syndrome. These include edema, lipodermatosclerosis, or stasis ulcers. Or simply you can see it, this post-thrombotic syndrome, you can simply say it complications of the varicose veins. So come to the symptoms. There will be dilated tortuous veins, there will be dragging pain, which is worse on prolonged standing or sitting, can be bursting pain on walking, can be swelling of the ankle, itching, edema, thickening, and eczema of the feet. There can be night cramps, appearance of spider veins in the affected leg, can cause discoloration and ulceration. Skin above the ankle may shrink, which is called lipodermatosclerosis, because fat underneath the skin becomes hard. This is because of repeated inflammation and fibrosis, bleeding, and local gigantism. The limb will be swollen and large as compared to the unaffected limb. So come to the signs. There will be superficial thrombophlebitis, ankle flare, spider veins, reticular veins, saphenavarics. This saphenavarics is a dilatation at the end of the long saphenous vein at its junction with the femoral vein. This is usually dilated end of the long saphenous vein. Talipes equinovarus, champagne bottle sign, and atrophy blanchi. This become there are some pictures that will clarify it to you. So this is a picture of ankle flare. Saphenopharynx You see, it is dilatation at the top of the long saphenous vein due to valvular incompetence. It can reach the size of a golf ball or can be more larger than the golf ball. The varix is soft and compressible. It disappears immediately on lying down. It exhibits an expansile cuff impulse and demonstrates a fluid thread. Champagne bottle sign, or you can call it inverted beer bottle sign. It can look like a inverted beer bottle. So there will be contraction of the ankle skin and subcutaneous tissues with prominent edematous cough. That's clear? All of you listening?
यस सर, आवाज आ
Yes,
रही
sir.
है।
Sorry.
आवाज क्लियर है और सारे जाग रहे हैं, सो तो नहीं रहे?
जाग रहे हैं।
अगर कोई जाग रहा है फिर हमारे साथ इफ्तिखार साहब ने भी ज्वाइन कर लिया, वो जगा देंगे। Acha, now come to the special tests or examination of. I also have a video for you people, because all of you know about the hernia examination, lump examination, thyroid examination, but this what they call this neurovascular everything, most of you people know, but this varicose veins, I think because we have less patients of varicose veins, so many of you will be not knowing about the examination. So I have also one examination video for you. Inshallah, it will be helpful for you. So there are some tests for examination of varicose veins. In this, the most popular one is the Trendelenburg test. It is used to assess the competency of saphenofemoral junction. In this test, the patient is lying flat, and we are elevating the leg and gently empty the veins. And then we palpate the saphenofemoral junction and ask the patient to stand while maintaining pressure. So one is the Trendelenburg test. This with thumb we press the saphenofemoral junction, and other one we can replace this thumb with a tourniquet test. So in this case, it will be called tourniquet test. So when we release the thumb, there will be rapid filling of the veins. So it will show us that saphenofemoral junction is incompetent. And if there is filling from below upward without releasing the thumb, then there is presence of distal incompetent perforated. मतलब ये है कि जब हम थंब के साथ जो सेफरम जंक्शन है प्रेस रखी रखते हैं, तो फिर भी अगर वेन्स डायलेट हो जाती हैं, तो इट मींस देयर इज problem distally. There are some distal incompetent perforated. While if the veins stay collapse, and when we remove the thumb and then it gradually fill, so it shows that the incompetency is in the saphenofemoral junction. You see this picture. It will clarify you how it is done. So the other is tourniquet test. This usually we apply a tourniquet to control the saphenofemoral junction. It has the advantages of moving the tourniquet lever, means कि इसमें हम multiple tourniquet, वो भी अभी इंशाल्लाह आपको ये next उसमें clear हो जाएगा, multiple tourniquet हम लगा सकते हैं, जबकि जो Trendelenburg test है उसमें सिर्फ हम thumb के साथ saphenofemoral junction हम block कर सकते हैं, not below that level. So there is another test which is called Perthes test. In this test, we empty the vein as above and then place a tourniquet around the thigh and ask the patient to stand up. And when they rapidly stand up and down on their toes, there is filling of the veins, which indicates deep venous incompetency. This is a painful test and rarely used nowadays. ये थोड़ा मेरे ख्याल में इसको मैं आपको क्लैरिफाई कर देता हूँ। पर्थीस टेस्ट में ये होता है, जैसे वो हम टॉर्निकेट टेस्ट करते हैं, फर्स्ट लेग को एलिवेट करते हैं, उसको एम्प्टी करते हैं, देन वी अप्लाई अ टॉर्निके अराउंड द अपर थाई, और पेशेंट को हम कहते हैं कि वो खड़ा हो जाए और वॉक करे। तो ड्यूरिंग वॉक ही विल फील pain. This will indicate the deep venous incompetency, or there is problem in the deep venous system. and the other one is Schwartz test. In this in standing position, if we tap the lower part of the vein, we can feel impulse. We can feel impulse at the saphenofemoral junction. This is called Schwartz test. अच्छा, ये इसमें पिक्चर जिसमें लिखा हुआ है फिगर 7.6, इसमें श्वार्ट्ज टेस्ट आपको बता रहे हैं कैसे परफॉर्म करते हैं। ऊपर सेफेनोफेमरल इंजेक्शन पे उन्होंने थंब रखा हुआ है, नीचे से वो वेन को टैप कर तो ऊपर थंब में इसको परकशन वेव या वो फील होगी। और ये परथीस टेस्ट जो है ये भी इसमें भी इंशाल्लाह नेक्स्ट उसमें आपको क्लियर हो जाएगा। परथीस टेस्ट ये आपको बताएगा भी कि डीप वेन कैसे आप डिफरेंशिएट करेंगे सुपरफिशियल वीनस सिस्टम इनकॉम्पिटेंसी से। ये कुछ टेस्ट हैं, ये आई थिंक कि आप लोगों के लेवल के लिए नहीं है, आप लोगों के लिए बस जो है ये ट्रेंडुलर बर्ग टेस्ट और टॉर्निके टेस्ट, ये दोनों टेस्ट काफी हैं। बाकी अगर आप नहीं भी करते तो खैर है, लेकिन वैसे ये फॉर द नॉलेज मैं आपके साथ ये शेयर कर रहा हूँ। ये आप लोगों के लिए इतने इम्पोर्टेंट नहीं है, ग्रेजुएट लेवल पे, पोस्ट ग्रेजुएट लेवल पे आपके लिए ज्यादा यूजफुल रहेंगे। जिसमें ये प्राट टेस्ट है, मोरिजिस कफ इम्पल्स टेस्ट है, ठीक है। उसमें आप पेशेंट को कहते हैं कि वो कफ करे तो वो आपको पल्सेशन फील होगी, एक्सपेंसाइल एक आपको इम्पल्स फील होगी सेफेनोफेमरल जंक्शन पे। अच्छा, now come to the complications of varicose veins. It can lead to bleeding or hemorrhage. Usually in the wards you have seen many cases who have this venous ulcers. So ulceration is one of the main complication of varicose veins. Phlebitis, pigmentations. So this extra pigmentation is usually caused by hemocysteine deposition. Eczema, which is a dermatitis due to this release of next complication is lipodermatosclerosis, which is inflammation and fibrosis in the subcutaneous tissue. Periostitis can be calcification of veins, equinus deformity, acute fat necrosis, especially at the ankle, and at the end deep venous thrombosis. Varicose ulcers, varicose ulcers,